Right, guys, welcome to the event. So today's really all around working in primary care. We've got Anthony Shoukry from Soar Beyond and Siddiqur Rahman, one of our co-founders at the Pharmacy Co-operative. They'll be talking about their experience and how they got into into primary care, what it's like working in primary care, and how you can get in there yourself as well, and the whole career path. I know with working community, a lot of people want to see what it's like on the other side, whether the grass is actually greener, and what the pay is, which is probably on top of the list for a lot of people, if not most. So yes, I'm gonna start with Siddiqur to introduce himself and just introduce himself, and then Anthony after to talk about his journey. So Siddiqur, over to you.
Good evening or good afternoon, all. Thank you very much for joining us today, especially giving up your precious free time on a Sunday afternoon as well. If I can just quickly, before I introduce myself, if I can get Toyd, if you can click on the next slide for me, please.
Yeah, can you see the slide?
Yeah.
Yeah, can you see the slide?
Nothing's changed.
Strange. Hang on.
Yeah, so I think that's come through. So we're presenting this webinar for the Pharmacist Co-operative, and we're pleased to welcome Soar Beyond, who are a pharmacist-led organisation dedicated to supporting the upskilling and competence improvement of general practice pharmacy and the pharmacy sector. Next slide, please. So for today's webinar, this is general practice pharmacy, the good, the bad, and the opportunity. I'm going to introduce myself and working from a community pharmacy background into the general practice. I've got Anthony Shoukry, who will be introducing himself after me. He used to work from a hospital pharmacy background. Then I worked in a PCN and now is working with Soar Beyond, and he will go through his journey as well. We'll then go through the day-to-day role as well. What does a typical day look like when working in general practice and primary care networks? We'll also spend a little bit of time about career development and support, and what does the opportunity look like for those who are already working into the general practice sector. And hopefully we'll have at least 10 minutes or more for any Q&A that people can continue to write it in the chat feature, and Toyd will present the questions to us at the end of the session. But feel free, even during the webinar, to ask any questions as we go along, and we'll go from there. And next slide, please. Okay, so to introduce myself, my name is Siddiqur Rahman. I'm one of the founders and co-director of the Pharmacist Co-operative with Toyd here. If I start my journey, I come from a community pharmacy background, did my pre-reg with the Boots the Chemist, and then following the pre-reg, I was initially a relief pharmacist for Boots at the central London branches before becoming store-based manager at one of the London Oxford Street branches. So I did that for about a year or a year and a half. And then after that, I turned my hands into locuming in the pharmacy sector because I wanted to get more experience and exposure in the different types of pharmacies around the UK. And I wanted a bit more flexibility into my working life, which I've done that for the best part of 10 years. And then towards the end of my locuming scene, I found that the rates at that time back in just after 2013, 2014, that the locum rates were decreasing. So I was trying to think what other career options are available for pharmacists as well, other than in hospital and industry, which was typically common in that time. Because I know I still got another good 20, 25 years to work as a career. And I've seen at that time there were some people that was working in commissioning, there's some already working in general practice, but it's quite niche. I saw an advert in the PJ, the Pharmaceutical Journal, when we used to receive them hard copies back then, and they were offering training to have a training session about what pharmacists look like when they're working in the general practices, as well as some work shadowing experience as well. So I'll be upfront. So the cost of that was £1,500, which is even now seems quite a staggering amount. And I just want to make that point about when it comes to courses, there are some pharmacists that seem to knock pharmacists if they have to pay for courses, because there's so many other free courses available as well, which is good, as fine as well. But some of the high level courses are paid, and to be honest, if you're wanting to upskill yourself and further your career and educate yourself, there shouldn't be any shame into wanting to pay for your courses yourself. Other professionals do that in other fields, including doctors and dentists, and I think Toyota will mention about what course fees are like for his wife, who's a dentist, in order to maintain their CPD and revalidation. So I've done that training course for about 3 days, and then within 2 to 3 months, the NHS England have announced plans to have a GP pharmacist pilot scheme, especially when there's shortage of GPs that they're trying to retire, and not many newly qualified doctors wanted to get into the GP scene. So they wanted to utilize pharmacists to work in the general practice. So I was one of the 408 pharmacists that's being selected to work into these practices, and I'm working in this worked in 2 surgeries in the Kent side, and it was a 3-year program. So the way that worked was, in the first year, 60% of my salary was paid from NHS England. 40% was paid from the general practices themselves out of their own pockets. The second year, it was 40% funded from NHS England. And then in the third year, it was 20% funded from the NHS England, and the rest was paid by the general practices. And at the end of the third year, hopefully you would have made enough of an impact for the practices to recruit you permanently and pay you 100% of the time, which is exactly what happened to me. And it happened just before the primary care networks started, and back in 2019. But the funding for the primary care is a lot different. And again, I'll get Anthony to explain that later on when he comes and introduces himself. So there are other roles that I do in pharmacy. I'm also a PDA rep as a regional committee member for primary care in the Southeast region. I also write a few journals, including articles about my role and the type of clinics that I do, which I'll start to share towards the end of the webinar into the chat group. And I'm also a community education facilitation lead for my PCN in Strood in Kent, where I try to upskill not just pharmacists, but other clinicians that are being funded through the primary care networks. So I'm going to hand over to Anthony Shoukry to introduce himself and talk about his journey so far. Thank you.
Thanks, Sid. Go ahead if you could go on to the next slide, please. So hi, everyone. My name is Anthony Shoukry. I'm a clinical services pharmacist with Soar Beyond. I'm going to try and make my intro as exciting as Sid's journey has been so far. But mine, like Sid mentioned, started off in secondary care. So I started as a pre-reg pharmacist in Northampton Hospital. And I continued in the hospital route, where I moved up north to Southport and Formby Hospital. And I did my Band 6 rotation, my diploma in secondary and tertiary clinical care, and then progressed into medicine safety specialist pharmacist and gastroenterology specialist pharmacist. And I was in those roles for a few years. In those roles were, quite clinical heavy roles, particularly with medicine safety. You get to see a lot of, I suppose, the errors and the behind the scenes that happens in secondary care. And I think that's what sort of spurred my motivation to eventually move into primary care. We saw a lot of errors and a lot of admissions into hospital for patients who could have easily avoided that admission into hospital had they been managed better in primary care. So for me, patient safety was a big drive. So after completing my independent prescribing in hospital, I decided to grow in confidence and use it on clinical ward rounds and progress my career a bit further. But then I moved into my lead pharmacist role in PCN to try and tackle this problem in the community and try and see if there was a way to improve the services and improve patient care to try and avoid all the admissions that were leading into secondary care admissions. So I worked for a GP federation in Southport and Formby as a PCN pharmacist, and we were in a unique situation because it was the first PCN pharmacist service that they had. So it was myself and a team of 2 other pharmacists who were given the daunting task of managing 17 practices and 125,000 patients in the population. And we'll get onto the responsibilities and the day-to-day roles of practice pharmacists and PCN pharmacists a little later. But I was in that role for a year as the lead pharmacist in that PCN. And we worked towards meeting the IAF targets in the PCN DES, which of course has changed massively now with most of the IAF targets being removed. So did primary care for a year, and then I wanted to take it a step further after that. Helping the community was great, but I wanted to see if there was a way to do that on an even wider scale at a more national level. And that's where my work with Soar Beyond comes in. So specifically, we're working on a national lipids management project at the moment, which has been really great. We've been working with almost 20 PCNs and supporting them to manage their lipids and their cholesterol, especially for the 2 new cough indicators. I also work as a clinical writer for the ITI Network. So many of you might be on the ITI Network, but we'll talk about that later in the coming slides as well. But we provide a lot of free e-learning resources. And then on top of that, I also do some therapy review services. So I go out into clinics and support with management of patients there. Most recently, I've been doing some OAB. I don't know if anyone's done overactive bladder clinics, but they can open up some very interesting conversations. So yeah, that's my journey so far. I've been at Soar Beyond for about 8 months now, so still somewhat new to this sector, but yeah, excited journey so far, and happy and excited to discuss with you guys how we got here. So yeah, that's me. Thank you, Sid. Go ahead, if we go into the next slide, we can talk a bit more about Soar Beyond and what we offer. So for those of you who haven't heard of us before, Soar Beyond have been running for, I think, about 16 years now. And 2 of our main offerings are the ITI Network and the ITI Smart Platform. So both digital tools to support the upskilling of pharmacists and PCNs. So the ITI Network is our e-learning suite of resources where we offer therapy reviews. We offer e-learning on a bunch of therapy areas, and we give you all the e-learning you need for these long-term conditions, as well as resources to then go back into your PCNs and back into your practices and implement the work that you've learned. And then we also offer the ITI Smart Platform, which is a competency assessment and capability mapping platform, which is not just useful for the pharmacy team, but actually for the entire MDT, and we use it in trusts and in PCNs, and you have the whole spectrum of pharmacists, technicians, nurses, doctors, everyone mapping their capability, and it allows us to then support them in using their skill set as best as possible. Next slide, please, Tawhid. So as I mentioned, the ITI Network is a free suite of e-learning resources. You'll see on the screen, we've got over 15 therapy areas in a bunch of long-term conditions, and ones that you may be running a lot of clinics for in practice. So, you could be doing COPD clinics, asthma clinics, overactive bladder, like me, is on there, diabetes, which is a massive one. And we're in the process of updating our diabetes e-learning, and a lot of these will update them as often as we can as new guidance comes out. And we're constantly adding new therapy areas. So we're currently working on testosterone deficiency for men's health. So I would encourage everyone to sign up. And when I joined Soar Beyond, I didn't realize just how much resource there was and just how good it was. I kind of wish I knew about it while I was still in primary care. So I would recommend everyone to check it out after the session. Next slide, please, Tahid. Sid, do you want to take over from here? And then
Sid, can you hear us?
I think you're on mute, Sid, maybe.
Oh, it looks like you're me. That's fine. You can hear me now. Brilliant.
Yeah, we can hear you
We
now.
can hear you now.
Yeah, just to follow on what Anthony was saying, I've been working in general practice since 2016 now, and I've utilised the ITI resources pretty much soon after I joined the general practice sector. I've been to various pharmacy conferences where the ITI Network have been sponsoring, and I've attended many of their clinical training sessions as well as the online webinars. So, definitely the resources there, which are free as well. Have been very beneficial, especially for myself, where I've been specializing in type 2 diabetes, and I wanted to sort of expand my scope of practice. And so I've got more e-learning modules on heart failure, tension, and I think now, as Anthony mentioned, is working on lipids, which is going to become the next clinical area to focus on, particularly with the new cough contract coming up. So I'll definitely recommend those who are wanting to join the general practice sector, as well as those who are already in the general practice scene, to utilize the resources that's available on the ITI network. And when you do that, I normally keep myself a portfolio as well, just to, as I say, show evidence of my scope of practice for the purpose of my indemnity, as well as for CPD revalidation, any CPC visits. So I've got a folder here. It's my own personal folder. A lot of it are training materials and CPD sessions and courses that I've done. You won't be able to see it properly, but you can see the size of it. I've recorded and printed out any of my study days, training courses, commentaries, into this file, which is ever expanding. So, so anytime you're wanting to upskill yourself, do keep a copy as well, a hard copy, just as evidence as well, which will be quite useful for your future career as working in the primary care sector. So if we talk about moving into general practice and discuss the pros and cons. So I'll come at it from a community pharmacy background, and hopefully Anthony will bounce some ideas off, especially coming from a secondary care background. So for me, the main pro for working into general practice, and the big difference is that you've got the opportunity to be working alongside with the multidisciplinary team. So Tony, if you just go back to the slide before, and one before, that's it. If you just leave it on that for now. So when you're working with not just with the GPs, you've also got access to nurses, paramedics, physios, physician associates, because we all deal with the same patients in our practices. So if there's any queries or concerns that we need to say a second opinion, or get some advice about how to best manage this patient, then it's good and handy to have those experienced healthcare professionals around the building. It's only you can just literally look next door, if not just phone through as well, and they can give you advice. And again, they'll do the same to me as well when they're recommending treatment and ask me if things are in stock, what's the alternative, etc. So at least you don't feel isolated compared to when you're working in community pharmacy, when you're the RP, the responsible pharmacist. You can feel a bit isolated at times as well. I suppose one of the other advantages about is the flexibility work. When I was at local or community pharmacist, you could be working at all hours, 7 days a week as well, private contract as well. Especially if you're working 100 hours pharmacy, you can start early at 6:30 in the morning, finish probably late till 11, 12, etc. But in the general practices, majority of them are Monday to Fridays, 9 to 6 generally. So my contract is literally a 9 to 6 job. Although there are some practices where they open a little bit longer as part of the enhanced service for primary care networks, where they have to work a few hours extra, a couple of hours extra a day, and from until 8:30, or a few hours on Saturday mornings. But generally, as I said, the work pattern seems to be better in the general practice sector. The other main advantage as well is when you are dealing with patients, you don't just deal with them right at the end. You've got the opportunity to impact patient care before a complication arises. And one of the ways you do that is that you have full access to patients' full medical records, which include pathology lab results and clinic letters, discharge letters, for example. And of course, that will help improve the clinical decision-making process. Whereas in community pharmacy, you may not have all that access, although there is SCR, summary care records. They just will highlight the current list of medications and the allergies, but you won't have access to the patient's recent discharges or lab test results, which can make a big difference into the next steps of treatment that you may recommend for that patient. So Anthony, I don't know if you wanted anything to add as well, especially coming from a secondary background to general practices.
Yeah, I think from a secondary care background, I would, for anyone who's considering moving into GP, I think the best thing to highlight is that more flexible working pattern, especially with out of hours, on calls. In some trusts they do, night pattern shifts depending on how big the trust is. So to have, although it is a busy Monday to Friday, it's nice that it is just a Monday to Friday, and you do get some time back in the evenings. You get your weekends back. So it's something that I really enjoyed by moving into primary care. But also I think in secondary care, it's very clinical heavy. So you see a lot of patients' lab results and a lot of their pathology. And an initial worry from some people, and I think I had it myself, is will I lose some of that clinical input by moving into primary care? But I think it's actually been the opposite, because like you said, you still have access to all their records and access to their path lab results. And it's a nice link, having seen it in secondary care. When you discharge a patient, I think actually it's a nice lesson learned, because often we are very stingy with what we write on discharge letters. And I think anyone currently working in primary care probably knows that secondary care aren't always great at giving details on their discharge letters. So being able to move into primary care and having seen it from the other perspective, it makes it easier when you're managing patients. So yeah, so the opportunities are there to make a big impact in patient care. And I think it's an exciting time to move into general practice, whether you're coming in from community, whether you're coming in from secondary care. It offers a good work-life balance while still keeping a lot of clinical input into your role, which is something I think it's difficult to find a balance of at the moment.
Okay. So that was the good part of the clinical practice pharmacy, and now also so a title says what is the ugly? What are the cons into working in general practice? Thank you very much, Toledo. In terms of what are the sort of disadvantages, I find that from speaking to quite a variety of practice pharmacists around the country, there is pressure to sort of get up to speed quickly. And it's an expectation, not just from the clinicians, but even from the admin as well, line managers, practice managers. They expect their pharmacists to be hitting the ground running and seeing patients immediately. I think that's because when they recruit other healthcare professionals, that a majority of them are ready-made, even junior doctors as well, to start seeing patients and to get going. Especially for pharmacists who've not worked into the general practice sector, because it's not really been taught before at the undergraduate level. It can be especially daunting if you don't know the computer systems, if you don't know how general practice works. I think it's good to have that background knowledge into the running of general practice, how they make the money, how they see patients, what is enhanced and essential services that they have to deliver and provide. So if you're new to the game, it can definitely feel daunting. And as I said, the expectation from surgery is that since you're already a healthcare qualified professional, then they sort of expect you to sort of know what to do in terms of the next steps and start running clinics straight away. No two general practices are the same, so also there's different expectations. So it's trying to get up to speed and manage expectations, especially from the beginning, just so your workload hopefully will be easier. And then you always say, I may not be able to do this right now, but if the right support and training, maybe I to do it in a few weeks, few months, etc. So that they can see that there's progression going on. So that needs to be made clear right from the beginning, especially if you're new into this sector. And of course, speak to other mentors and colleagues, pharmacy colleagues as well, who's been in this field, just to help you settle in straight away. One of the other big cons is there's a lack of obvious structured career pathway and salary expectations in general practice pharmacy. And again, we're still quite newish into the scene because it's only been just over a decade that pharmacists have been working. But in terms of the what are the career progression, it's not always crystal clear because as I said, no two general practices are the same. So everyone's got the different remits in what they expect the pharmacist to do. So again, I know with the networks like the ITI Network and the Clinical Summit, which they'll actually explain at the end, it's good to get an idea as to how pharmacists sort of progress into the role and what will be the next steps and how you can make yourself proactive to get to that stage as well. Sometimes the GPs may not have enough time to be supervising and mentoring you because it is quite a busy workload, especially since the pandemic as well. The patient waiting to get appointments to speak to the clinicians are higher than ever before, especially with the shortages of GPs and nurses around the country. So trying to get that mentorship is not sort of consistent across the board. It can sometimes feel very target driven, especially where we're talking about cough, which sounds similar to targets in community pharmacies as well. And there's obviously a lack of standardized process across multiple practices, especially in England with the invention of the primary care networks, because it's done at a local level. So you don't get that same consistency across the board. And again, at primary care level, I think if Anthony can sort of explain a bit more further about how that can be a disadvantage, if that's okay.
Yeah, so just to echo some of what Siddiq said, that I think because it is a new and rapidly evolving role, we're still figuring out, how the roles develop, and there's a lot of opportunity out there to shape some of your role and shape how you want your career to develop. There's opportunities, I've seen it in my PCN, opportunities to work as a lead PCN pharmacist, opportunities, some of my colleagues moved into advanced clinical practice and worked with the care home team. So they weren't in the pharmacy team, but they were pharmacists by background. And they were doing reviews in the care home team with an MDT, with a consultant, with a GP, with the nursing staff. So the opportunities are there, and especially in new PCNs, new areas, growing areas, you're given freedom, from a PCN perspective, given freedom in how you manage those targets and how you set up your services, as long as you meet the target, which I suppose is a con. But I would say the other thing as well is that, from personal experience, when we were hiring, is the salary expectations can be a bit difficult. Again, we're hoping that as we understand more about the role and the role develops, there is more structured offers and structured expectations. But it can be difficult, I know, from secondary care perspective, to attract pharmacists who, I suppose, get that structure from band 6 to 7 to 8 and can see their progression with diploma and independent prescribing and the expected increase in salary. But again, this is something that I think can be somewhat negotiated depending where you work. And like Sid said, it's important to keep a portfolio, because everything these days is portfolio based. And if you're looking to go into advanced clinical practice or emerging roles like consultant pharmacist later in your career, a lot of it is proving your competence via your portfolio. So a lot of these cons are current cons, but I would say I wouldn't let it put you off, because I think a lot of these are things that primary care will be addressing in the years to come as we understand the role better.
That's great, Anthony. Yeah, I think just to echo what you're saying regarding the cons, although in England especially, the structure isn't sort of formalised yet. It's already well established. If you're working in general practices in Scotland and Wales, there seem to be sort of up the game ahead of the game. They've already work in a banding scheme and to do certain courses and qualifications and have enough experience and exposure to move up the bands, and hence your salary moves up as well. We don't have that system in England yet, so I'm obviously hoping we'll see the more pharmacists that are working in general practices that will become evident, and hopefully there will progress more, because again, as we'll explain later in the slides, what are the impact of general practice pharmacists make into the respective practices, and it is very significant. So we need to sort of raise our voice and speak louder and shout from the rooftops, because if we do the bare minimum and do the, what the soldiers tell us, and we don't talk about it enough and showcase our work, then things won't progress. So I think one of the advice I would say is, when you are working into this sector, is to be proactive and to make sure any consultation you do, you sort of have a spreadsheet, show some evidence and outcomes, just to highlight to not just your line managers, but to everyone else, where your clinicians, patients, that the work that you do. Again, there is a lot of fantastic work that general practice pharmacists have done already. It's just they haven't got it written down in black and white. So I think if we all start to do that, then we can use that evidence to hopefully showcase our talents. So if Todd, if you can click on the next slide for you, please.
Yep. So at Soar Beyond, we sent out a career development survey or career challenges survey to our network of pharmacists, and you can see the results on the screen from 92 GP pharmacists, which kind of echoes some of the cons that we've just discussed. If you look at those top three really, the main ones, lack of pay progression being the main one, no structured career pathway within the PCN, and lack of clarity about career options, being the three main challenges or obstacles that are either putting off people from staying in GP or joining GP. And I suppose this is the purpose of this webinar and the clinical summit, the ITI clinical summit that we'll go into later, where we get to delve a bit more into the career challenges, and we have a career panel that can support any further questions that we might have outside of this session. So yeah. Next slide, please, Tawhid.
I can sort of mention about this particular slide. So quite a significant number of pharmacists are working into general practices without any prior primary care background. But you can see just from this slide alone that there's a lot of variables that both community pharmacists have and take with them into the sector. So specifically pharmacists, managing minor ailments, administration of vaccines like the flu vaccines, consultation skills, and understanding and delivery public health programs such as weight loss management and smoking cessation programs. Community pharmacists are already doing that right now anyway, and there's a lot of those skills they can easily relay that into the general practice sector. So it's just to utilize and enhance your skills into that role as well. So don't be afraid to showcase your talent from the your sector that you worked in before, because again, a lot of those skills will be very valuable and very useful. And there is a shortage of clinicians anyway in general practice, so so they do definitely need pharmacists, which will again show you what the impact of them is. But don't be afraid of applying to the sector if you haven't had any prior experience, because a lot of the skills that you have already, if you mention that at the interview stage, they'll definitely be interested and take you on, because you are healthcare professionals in your own right. So so be brave and absolutely highlight your talent.
Yeah, and what I would add, Sid, if I may, just quickly, is that I think the thing that from even from community pharmacists that I have spoken to, friends of mine who are looking to make that move into general practice, the main thing on there is probably their worry of that background clinical knowledge, particularly, you know, compared to some hospital colleagues who might have had that from their diploma or from, you know, board-based learning. But what I would say is that this is something you can develop, whether it's, you know, obviously the primary care pathway is a must for the R's roles, but this is where we come in with the ITI network. And, you know, I can't honestly go on about it enough, that the fact that it's free even baffles me, and I work here. So we offer, you know, the long-term conditions that you'll probably see in practice. And the best thing is that it gives you the opportunity, with what I said earlier, to kind of carve out that role that you want for yourself. You can become a pharmacist with a specialist interest in a topic within primary care, you know, whether it's diabetes, whether it's, I think a lot, you know, we met a lot of pharmacists recently who are looking to do dermatology. We have a lot on acne and psoriasis, and you have the opportunity, whilst it's still a growing sector, to develop your interests and find out what you really enjoy. And you get that with primary care. So I wouldn't let, you know, clinical knowledge at least, you know, be the thing to draw you back.
Thank you. Next slide, please, Doyle. So I'm just going to highlight this slide about what are the difference between roles in general practice for pharmacists. So there's a general practice pharmacist, which is what I am, and I'm employed by one practice working for that particular surgery only. And then there's PCN pharmacists who may be working across multiple practices within a specific area. So Antti will be able to explain a bit more about that. But if I talk about my role as general practice pharmacist, some of the activities that they include medication use, polypharmacy use, on or medication regularly. There are some pharmacies where they are attached to a care home at the particular practice. So they visit the care homes and do some reviews or potentially de-prescribing as well. We also do long-term condition management, so things like diabetes, hypertension, asthma, COPD, and now lipid management. So we take the ownership and not only just prescribe, but also manage the condition as a whole. So it is important to highlight that it's not about prescribing medication, it's about the whole package, about lifestyle advice, about referring to the relevant providers like social prescribers. Do they need support from the home to help better manage the long-term conditions? So it's giving that extra tailored support for each of our patients in the general practice. We also deal with repeat prescribing and any prescription queries related to that as well. High-risk drug monitoring, again, is very important from a patient safety aspect. We need to make sure that whenever they're being prescribed those high-risk drugs, such as DMARDs or lithium, warfarin, etc., that they are on the right dose for the right duration, and it's safe to continue to be prescribing them. We also work, as I said earlier on, we work alongside with other healthcare professionals because we all see the same patients, and we utilize our own specific skill sets to help best manage our patients. In addition to seeing patients or dealing with patients, we also have clinical admin work that we have to do. For example, reviewing clinic letters, discharge letters, updating the patient record using a program called DocMan. And we also get involved with cost and income generation, which is basically managing patients on a specific clinical criteria, and see that we are actually managing conditions in a safe and in current guidelines and evidence. So we do that for each clinical condition for our particular practice. If I can get Anthony to sort of delve in a bit more about the typical roles that PCN pharmacists do, that'd be great.
Yeah, thanks, Sid. So as a PCN pharmacist, like Sid mentioned, you're working across the whole primary care network. So it could be multiple practices, you know, as few as 2 or 3, or if you're unlucky, up to 15, 16, 17, depending on your area. And the role is a bit different. So you're not employed by the practice. So you're not based in one particular place. You might be split across a few or working across multiple. And your roles are more based on delivering the PCN incentives, delivering that PCN DES. the work is more focused on services and pathway transformation. So, what can you integrate to develop a work stream, develop a particular service? It may be clinical, maybe non-clinical. You have more variety working with the team outside of the PCN. A lot of social prescribers, a lot of secondary care input, from working with clinical specialists and trying to integrate, referral processes. For myself, I was the prescribing lead for our PCN, and it's again something to work up towards. And yeah, it's a very different role. I was employed particularly by a GP federation, which made it even more different, because we work with the care home team, the enhanced, out of hours service team, enhanced care team. And in a lot of the times you're asked for support in those various areas, the same way that the practice might enlist your support. So I know for myself, when I worked in some of the practices and I became more familiar with the team there, they would often ask if I could do some medication reviews or look at some discharge medication lists. So it doesn't mean that your responsibility is completely isolated compared to the GP practice pharmacist. It just means that your priorities may be different, but you'll still get a mix of everything.
So next slide, please. I'm going to highlight what are the few tasks and activities that we do for pharmacists working in both general practices and in primary care networks. And it's not just historically, it used to be just mainly medication reviews or generic to brand switches or vice versa. We do a combination of face-to-face and telephones for any medication reviews and queries and advice. We have annual medication reviews for patients on chronic or long-term conditions, and also for those who have newly joined the practice, we do a medication review then as well, just to make sure that the transfer of care is consistent and safe for them. We also deal with the management of patients, those who have diabetes, heart failure, asthma, COPD, hypertension, for example. And we take a key step into best how they can get the next medication, how they can best optimize the medication, and hopefully which will improve their long-term conditions as well. We'll also implement and share best practice in terms of their repeat prescribing and increase utilization of using EPS and electronic repeat dispensing as well, which will hopefully make the workload easier for both general practices and community pharmacies as well as being easier for patients to order their regular repeat prescriptions. As I mentioned before, we also take a key role into monitoring patients on high-risk medications like warfarin, lithium, and DMARDs. We also conduct clinical audits, which is a lot to do with the medication safety aspect. Again, it's required for CQC inspections, as well as good clinical practice as well. Next slide, please. So we do also work with our management team and local ICBs in terms of how to best optimize and prescribe costs effectively for patients and for the practice. And that's one thing I wanted to highlight there as well is which some pharmacists may not be aware of, is that there isn't a specific prescribed budget per surgery that a doctor has to be limited to. I'm not saying it's unlimited, but in terms of the cost, if the patient needs a medication, then of course the GP will prescribe that. And I think in terms of any incentives is coming from the local medicine management or ICB, that if we're able to at the same time prescribe it more cost effectively, obviously using the latest kind of guidelines and evidence, then we'll get incentivized as well, as long as patient care is not compromised. We also help develop relationships with the local community pharmacists as well, and increase the service and increase access as well as decrease, which unfortunately at the moment seems to be stock shortages, which seems to be getting bigger and bigger with each passing year as we go by. We also do other medicine optimization work set by our local ICB trust or emergency management team, and we use tools like open prescribing or e-pact data in order to see what drugs are we prescribing. Are we prescribing too much, too little? Is it in line with other surgeries or other local areas? We also carry out medication care plan reviews for high-risk patients and update them as well, depending on their chronic condition and life expectancy as well. Next slide, please, Toidal. We also deal with discharge letters, clinic letters, amending medications onto the patient record, just so it's live and consistent, as both and well. Any discrepancy, we'll have the opportunity as pharmacists to be liaising with both our secondary care colleagues as well as primary care colleagues in community pharmacy to update their weekly dossier boxes, for example. We also provide clinical support and training for our clinicians, even non-admins like our reception and practice staff members as well. We're also responsible for ordering blood tests as well, particularly for high-risk drugs, as well as if you're trained, interpret blood test results. Again, it's not just for high-risk drugs as well. If you're dealing with a specific chronic condition, like for example, I manage my type 2 diabetic patients, I review the blood tests and make changes to the treatment accordingly. We also conduct level 2 and level 3 medication reviews. So level 2 is mainly note-based medication reviews, see if the doses are correct and in line. Level 3 is having the medication review with the patient in front of you or on by telephone, with or without the carers. A lot of the primary care pharmacists go a step further and do structured medication reviews. Again, it's targeted at a specific group of patients. For example, care home patients, patients on high-dose opioids or 9 or more medications for polypharmacy reviews. So these are more targeted to make patients the best use of their medication as well. We administer flu vaccines, probably also COVID vaccines now as well for at-risk groups as well for the NHS. And even probably more other DES-related work for the primary care networks. Next slide, please. So this is sort of a typical timetable for pharmacists working into their surgeries. Again, as I said, no two practices are the same, so it can vary. And you can see from that, again, no 2 days are the same either. So mine looks slightly different to that. So the way how I work is in the mornings, I tend to deal with any prescription queries, I do medication reviews, the hypertension reviews, depression reviews, and any changes from the hospital discharges as well. Then in the afternoons, some of the week I deal with my long-term condition clinics like hypertension or heart failure or COPD. Sometimes I spend time doing admin and updating my clinical audits, making sure that all the prescribers are prescribing safely and appropriately, and doing any patient safety, medication safety work, such as the MHRI alerts and acting on them. So if Antti wanted to have his thoughts as well about the typical day-to-day role of a primary care pharmacist.
Yeah, so I think this timetable is more, like you said, if you're practice-based or employed by one or two specific practices. I think from a PCN perspective, it can look very similar or incredibly different. So I know for myself, for the practices that we had, we split between myself and my two colleagues. So we took about 5 or so practices each. So we split it per day. So it was Monday, one practice, Tuesday, another practice, Wednesday, and so on. So each day was a different practice, and the work that you're doing for each practice varies. So for some of those practices, they had their own practice-based pharmacist to do the type of roles that you're seeing on screen. So when I would be going into those practices, it would be to manage the specific work streams that met the IIF target. So a lot of my work was on the CVD IIF targets and meeting a lot of those blood pressures and hypertension monitoring. So the work can vary depending who you're employed by and where you work and how many practices you work across. So this is just an example, but it can be more daunting than this if you're working somewhere incredibly difficult, or a lot less daunting than this if you're in a well-funded and well-staffed area.
Yeah, I'm just conscious of the time as well. Just going to wrap up the next few slides. So next slide, please, Toidal. I just want to highlight what the impact that general practices have made and will continue to make, hopefully. Recruiting both practice pharmacists and primary care pharmacists, you're making the most of the use of the pharmacist workforce as well. We can help reduce, change, and not just change the work of GPs, but also sometimes enhance the care of the work that we do for our patients. We also increase patient access for primary care, because again, we all know how hard it is for patients to get an appointment with their respective GPs and doctors. So having pharmacists available as well is such a game changer, because even like medication queries, if pharmacists weren't there, those type of queries that can easily dealt with pharmacists would have gone directly to the GPs, and there would have been appointments taken up by GPs for those queries that can easily dealt with pharmacists. So I think us being into this sector has definitely opened up more appointments for GPs, because as I say, if it wasn't there, it would have got a lot worse if it wasn't already as it is at the moment. We also invent the best principles of best practice for medicine optimization for our patients. We also improve healthcare outcomes for our patients and increase patient safety, both from managing the condition as well as the medication that they're taking. We have also helped to increase communications now between surgeries and community pharmacies and secondary care, and we act sort of in the middle to help increase dialogue and get things done quicker. And we also help change the perception of behaviours of patients when we're talking about healthcare outcomes as pharmacists working into this sector. Next slide, please. So I think Anthony will explain about the resources available on the ITI network as well.
Yeah, so in terms of we can skip the speech bubbles though here, but it gets the idea of, if you're looking for options on where to start, what you can look for, where you can get the support. I know we've spoken a lot about the ITI network today, so I won't dwell on it too much longer, but you can see on the slide that the offerings that we do have are to give you that insight into what it takes and the education you need for applying yourself into primary care and into long-term condition management, and we provide free resources and implementation tools to support you with that, as well as live events and face-to-face sessions, which Towhid, if you move on to the next slide, I can introduce. So we've got, once you've signed up to the ITI network, you'll be able to access both of these events for free. We've got a clinical summit in Leeds on the 28th of September and another one in London on the 2nd of October. The one in London is waitlist only, so I would still encourage you to register, as you might still be able to get a spot. Then the one in Leeds is booking up very quick, so I would encourage you to go. We've got CKD, lipids as workshops and being discussed. We've got expert speakers coming in to talk to us about hepatitis C, and we've got a career development panel who will be able to expand even more so on what we've discussed today. We've got some of our own associate directors on that panel from Soar Beyond. We've got consultant pharmacists, experts in the fields, really. So very exciting to listen to them, and hopefully we can see as many of you as possible at the clinical summits. And I'll be there, so be sure to come and say hi if you do attend.
I'll be there at the London event as well. So if you
Amazing.
grab me as well in London, then yeah, I'm more than happy to network. And for me, just a final point is when it comes to these training sessions, for me, in addition to the content that's available, I also find valuable about the networking opportunities as well. So when I was doing courses early on in my general practice career, when you go to these type of events, I found a lot of good networks and colleagues during our breakout groups or break times, lunch times, and kept the contacts, and they have definitely supported me in my career, and hopefully I've done the same for them as well. So getting a few contacts and adding them to your networking is so valuable, and I think the fact that it's face to face, which again we've missed out a lot of that since the pandemic, and I think we might all have like other Zoom fatigue, which is ironic. I know we're on a Teams webinar at the moment, but I think it's important to have this face-to-face meetings as well, just so you can build up your networks, which will hopefully be able to share best practice in your working career. Okay. I think, Toyin, I think you're on mute.
Yes, so can you hear me now?
Yeah.
Okay, cool. Right. So thanks for the for all the information. I think that's been really useful. Obviously, especially with me, my background in community, I did have a lot of questions, and I think that kind of covered everything. And anyone who's available free on 20th in Leeds or around Leeds in October in for London, I would strongly advise going to the event. I think it's going to be really insightful. I've seen some of the videos from the previous events, and I think it's really important for us to kind of looking at areas, and a lot of us are purely focused on community, and we don't always think about what else is out there, or we're just we're tired of working in community and we want to look for something else. And just go to these events, go to clinical training events, and see what's there. You might really like it. It is definitely a lot more clinical than community work. So so thank you guys for both for all the info and your background on the clinical both PC and in general practice, how all that works. Does anyone have any questions? No? I've not got any questions from anyone. I think you guys really answered all the questions. Oh, hang on. What salary would you expect to be starting as a practice pharmacist with no previous experience? For example, lowest 30, 35K for 40 hours? Or what would you say?
Yeah, I was expecting people to be asking questions about salary. So I think again, it's difficult to say because there's so many inconsistencies across the board as well. So I give you a little bit of background before I sort of give a specific answer. So when I started working in general practice, as I said early on in my career, the surgeons were paying the salary or partial contributing to salary in addition to the funding from the NHS England. But since primary care networks were introduced in April 2019, the way the funding worked was that they're sort of using the NHS Agenda for Change pay band scales, where it's not applicable really for general practice, because at the end of the day, in surgeries and general practices, they are a private business, just like community pharmacies are. You don't hear community pharmacies getting paid in banding scale.
No.
The only pay band scale that's applicable in pharmacy is those who are working in a hospital, NHS hospital, not private, and if you're commissioning ICB, CCG, the previous known. So again, as a Pharmacy Co-operative, as one of the founders, I'll be open and transparent. So what I'm now as working in the general practice for over 7 years. And again, in addition to the work I do, I also take the lead on clinical training. I'm the diabetes lead, the cough lead, and also the lead for prescribing as well. So my salary is over 60K at the moment. Again, as I said, I'm also a prescriber as well. So for those who are new and they've not had any prior general practice experience, it should be close to between 38 to 40K initially. But the idea is when you're become more experienced and you've got enough exposure and become a prescriber and start to actually make a difference, then the salary should be increasing. Unfortunately, where it's the moment in primary care networks, that's not been happening. I think the expectation for those pharmacists working into this sector is that when they first start primary care networks, they have to go for an 18-month course with CPPE before they're allowed to do the prescribing course. And for them, the expectation is once they've acquired both CPP pathway and the prescribing, that the salaries will move up. But I think
how fast does it move up though once you've got the experience?
It doesn't. That's the problem. A majority it doesn't. So I think a lot of the pharmacists, as soon as they leave and work in another practice where they actually want a ready-made pharmacist, or they will go back to community. As long as they got their prescribing qualification. As I say, each practice is
If I can just add, Sid, sorry, just to add to that answer, I know, I'll give some transparency from when I was looking for pharmacists. We were going out for around the 32K mark to look for, like you said, matching that NHS agenda for change to try and match what hospital would offer to try and attract some pharmacists. And we didn't manage to attract any. And the reason being when we asked for some feedback was the progression or the pay difference in hospital for band 7 pharmacists was higher. So we couldn't attract pharmacists who could potentially be on the verge of going into the 36Ks, 38Ks, 40Ks, 42Ks, etc. So to answer that question, I suppose 30 to 35, depending whether it's practice-based or PCN based, would probably be a fair estimate for a full-time role. But that 5K discrepancy, could depend on how their system is set up. But like you said, with the CPP course and with prescribing, to come after, if you're not already a prescriber, then because even prescribers have to do that 18-month course, regardless if they're funded through the ARS roles. But yeah, the progression is there to take on leadership opportunities to increase that pay scale, or like yourself said, to go into certain specialties and certain clinical areas that add to that.
Yeah, so it's you've definitely got to be more proactive, and if you just do the bare minimum, you're unlikely to be given a higher salary. So it's up to the onus is on you to, as I say, showcase your talents. And one of the ways to do that is to do some quality or QI work as well, and show evidence that how much of an impact that you've made when you were working to the respective practices as well. In terms of the if we're going back to the pay from the NHS funding, I think the mistake that they sort of made from NHS England is that they say it's maximum reimbursable, but it doesn't stop general practices to pay the funds out of their own pockets as well. So they can get the funding from NHS England, and then those who have got enough experience, exposure, and are well settled into their roles, the surgeries can, if you wanted to retain them, pay out their own package, say another 5K more, or up to 10K in addition to the NHS funds. I think I'll send a document in a minute on the chat, but it sort of gives the rough salary figures for practice pharmacists or clinical pharmacists as they call it, and they're going from band 7 to band 8A. But the figure that you see on the sheet includes on costs. So I think if I'm looking at it now, currently there's been a 5% pay increase from the 1st of July. So for those who are already working in PCNs, and make sure you get your 5% uplift as well. So on the spreadsheet, it will say an annual equivalent maximum reimbursable role is 62,340. That doesn't mean that the pharmacist gets £62,000 themselves. That includes the on cost, which you have to deduct anything between 10 to 15K, because that on cost includes your pension contributions, your national insurance, sick pay, holiday pay, etc. So if you deduct that, which is why roughly about 45K was probably the average what primary care pharmacists are getting at the moment. But as I said before, there's nothing to stop general practices or PCNs or federations to pay on top of that if they value your work that you've done for them so far. So
Okay.
as I said, you need to
So
make
I've got one question about the salary, and I think this is going to probably resonate with a lot of the people that are working in community. What's the chances of primary care ever matching or beating the salaries in community pharmacy? Do you think that will ever happen, or?
I think it may do, not right now, because especially since the pay seems to be at the moment better in community pharmacy, especially locuming as well. And I've seen a lot of pharmacists, once they've acquired their prescribing qualification, they leave the general practice and private care networks to go back to community, because they know, especially from 2026 onwards, there's going to be newly qualified that are going to have their prescribing qualification from day one. So they may not be using the prescribing qualification right now, but it's something good for them to have, because there's so many roles for pharmacists to be working remotely using prescribing. So I think it's a good army to have. But if a lot of them are leaving primary care networks because of this, again, similar to the GPs, they're going to be shortfall clinicians. And since patient access is key, especially now more than ever before, I think that surgeries and primary care will have a rethink to think, okay, how do we retain these pharmacists? We need to be paying what the market rate is at the moment. So as I think it will happen, but
Okay.
it
I
won't.
think at that point you'd probably get a lot more interest. And one thing that I still see get a lot of messages from people wanting to move into primary care, general practice PCNs. But one thing that always comes up in every single conversation is the salary is much, much lower. But even then, they're still interested. So I think there will be a lot more people interested if they were able to match or come very close to the salaries in community pharmacy. So just got another question from anonymous user. With PCNs no longer existing in the future, what will this likely mean for funding for primary care pharmacists? You can either one of you guys can take this one on.
Yeah, I think again, it's the funding, as it is at the moment, there's an end date of 2024, end of March 2024. But I don't think they'll stop the funding. It's not again 100% confirmed, mainly because they need pharmacists in general practice. If they stop the funding and pharmacists all of a sudden stop working, or surgeons when they're able to get funding for the pharmacists, it's going to cause a serious workforce shortages. So I don't think from what I hear at the moment that it's going to be stopped definite. But again, they might call it something different. But there's definitely still opportunities for pharmacists to be working in general practice as it is at the moment.
Okay, we've got one hand up from Loveth. Loveth, do you want to unmute yourself, or I can unmute you? Hi. Hello? No, she's gone. Okay, Dalia, you want to say something?
Yeah, hi, good evening. So thank you for the informative webinar. I am new to PCN pharmacist, so I moved from the community barely like a couple of weeks ago. So I do have two questions. The first one is that what sort of like training expectation I should put in my head regarding, I mean, they have been put me in shadowing the pharmacist, senior pharmacist there, those kind of things, but there is no fast and hard rules. So I don't know exactly what should I expect from training point of view. That's the first thing, being coming from a completely different background as a community, of course. The other thing is that what should the employer expect from me? So in the first, let's say, 3 months or so, what sort of things I should be doing currently?
I
Yeah,
think
thank you.
quite a loaded question there, but I think it honestly depends on your relationship with your employer, whether that's the PCN or the practice. I think for the first 3 months, a lot of it is trying to get up to speed with the GP clinical system, with the way the practice works. And like Sid said, no two practices work the same. So, reception, admin, they're probably going to be your best friends, I would say, in the first 3 months. Familiarize yourself with the way of working, start to speak to the nurse practitioners, the GPs, and become comfortable in your working environment. And that will help you understand what your role is. You'll find the gaps that they need you to support with. And that will be in long-term condition management, most likely, especially if you're starting out quite new. In terms of training, the CPP primary care pathway is like a standard that everyone has to go through. So that will offer you a baseline of training. But after that, I think it honestly depends on what you are interested in and what sort of career line you want to head down. So, you might see some therapy areas that interest you in particular, like diabetes, hypertension, asthma, COPD. You may want to use some of your shadowing time to shadow an asthma nurse or shadow diabetes nurse or someone in that field. Because when it comes to then applying for your prescribing, it might be something then you want to pick up. So the opportunity is there for you to almost carve out the career route that you would like to take, and the specialties that you would like to look after, I suppose, in terms of patient population. But the basics would be, if you're working for PCN, is to understand your patient population. Some are very care home heavy, like I was. Some are in very deprived areas, so lower reading and writing abilities, and they have their own difficult management. So understand your population area, understand the needs of your population, and communicate as best as you can with your colleagues and the rest of the MDT, because they need you just as much as you'll need them. They'll need you to support them with meds reviews, with long-term condition management, and you'll need them for the complex patients. So I'd say for the first 3 months, 6 months even, is a settling in period and finding your feet, and upskilling yourself as best as you can in whatever therapy areas you might be working in.
Right, guys. So we're at 6:15 now. Just going to take one more question. Got one question asking, what's the benefit, this is to Sid, of their becoming an ACP?
So the advanced clinical practitioner role. So if you've already done the prescribing or you wanted to become an ACP, what does that mean in primary care? Is I think if you're interested in running minor illness clinics, and I just want to stress the difference between minor ailments that you see in community pharmacies and minor illnesses, conditions where it's a lot more serious and needs to be have a specific experience and exposure first, working under clinicians like GPs or advanced nurse practitioners before you take on that role yourself. So what the benefits is, if you're doing a prescribing role, they don't get to teach you the clinical physical assessment skills, whereas they do the ACP course, and I found that very valuable as well. Even though I'm not running my own illness clinics myself, when I'm doing my long-term condition clinics, recognizing signs of red flags or signs of deterioration is very important, just so I can signpost to the relevant clinician or the relevant team or do the referral in a timely, appropriate manner. So if I can see any sign of, for example, some heart failure clinic reviews, yes, I'm optimizing and managing the medications, but if I can see during the course of my reviews that if patients are getting signs of worsening conditions such as ankle or leg swelling, shortness of breath, fluid, then something that I'll definitely raise and make appointments with the doctors probably straight away, or do the necessary referral to the heart failure clinic if they're already under their management. So, and when you do the ACP course, it sort of highlights you that various different differentials that are available that you might not have learned at pharmacy undergraduate level or at prescribing level. So it's quite good to expand your clinical knowledge as well. So it's definitely worth doing. And as I said, the more pharmacists are becoming ACPs, literally the world is our oyster, and we can utilize that to specialize in a specific condition as well. Thank you. You're on mute.
Yeah, sorry. I hope that answers your question. Right, guys. So it's been a great event. I think we've answered a lot of questions. We're going to record this. We've recorded this event, so we will post it on our YouTube channel and I'll share it across the network. If you've got any other questions, it's on Telegram, and Anthony will be at the event in Leeds and in London, so you can ask some questions live. So thanks again for coming. Thank you, Anthony and Siddiqur, and we'll see you guys next time. Good night.
Cool.
Thanks, everyone.